Hi guys. So this is the next presentation in Module 5, and we're talking here about the OTs across the lifespan in the treatment settings that OTs work in. So this first slide here talks about the work setting trends and how they've shifted and changed from the year 2000 to the year 2014. I was looking at the AOTA website, and they said that the next one was going to be updated in 2018, but it doesn't seem to have yet been published. So anyway, so this is kind of what we're going to go with. But as you see, you can look through these, and it looks at the different percentages. But just looking at 2014 column, you'll see that for OTs, the highest prevalence for OTs to be working in a setting is really within a hospital setting, followed by a school, and then followed by an outpatient, well, actually followed by skilled nursing facilities, and then a freestanding outpatient setting. When you look at COTAs, the highest prevalence for them to be working in is in a skilled nursing facility or a long-term care facility, followed by school and then a hospital setting. So you can kind of look at when we're talking about the levels of supervision and the changing in the population. COTAs are much more fit to in their education to be working in a skilled nursing care facility and then in a school setting. Somebody with a setting that is going to be working with individuals for longer periods of time. So settings can be characterized in 3 different components. First is the administration. Second is the level of care, and the third is the area of practice. They can also be, when we're looking at areas of administration, they can also be categorized or grouped in settings such as a public agency, which looks at a county or state hospital, early intervention or school system, a private nonprofit organization such as a community agency, maybe Easter Seals or the United Cerebral Palsy Association, or a private for-profit setting, much as like a preschool setting. And we're going to talk about these much more in detail. So when we talk about the levels of care, we're going to talk about acute care. This is when we talk about acute care, this is a hospital setting. This is where an individual goes when they are acutely ill or have acute medical needs that need to be taken care of. Then there's the subacute care, which is that goes when an individual no longer needs the intensive medical attention, and now they're looking at more of a rehab potential or rehab needs, but they still have some sense of medical needs that need to be taken care of. That's when we talk about subacute care. Then we get into inpatient or outpatient rehab. This is now where that same client that was in a hospital has transitioned to needing less medical care and more rehab. Now that they're in a rehab setting, this is now the sole purpose for them to be ready to go home, is that they need intensive therapy rehab or therapy needs. So the medical attention isn't quite as intense. Then we get into short-term or long-term care, which is in a residential setting. This is when we're talking about somebody that maybe is in an assisted living, or maybe they're in a short-term residential care unit until they're able to go home. Or maybe they're in a skilled nursing facility, and that's going to be their last living setting during their lifetime. Then we get into home care. We have a couple of cares for this. One is pediatric. So we do home care through early intervention. This is servicing children 0 to 3 years of age or 0 to 5 years of age, where we do services within their home setting prior to them going into a school setting. But they can also, an individual can also receive home care if they're an adult. Maybe they've had a knee replacement or a hip replacement, and they go home from the hospital, but they still need therapy. They could get therapy services in their home. Then you get into the community-based care. This is looking at a preschool setting, a daycare setting, Easter seals, we kind of talked about that. And then the institution level care. This is when when we think of institutional care, we think of more in the mental health realm. So this is when an individual is in need of intensive medical attention or intensive counseling or therapeutic intervention. They can be done in an institution or a psychiatric care facility. So pick your work setting based on your location. So if you think about where you're located, are you located in an urban area, much like a city, a suburban area? This is maybe a suburb of the major cities area, or a rural area. This is something that you have to drive to get to a city, maybe 30, 40 minutes or even an hour to get to a large city. So this just kind of looks at the work settings that are based on your location. I'll just let you take a minute to look at that. We're not going to spend a lot of detail on that. Just want you to be aware of some possibilities. So now we're going to break down looking at the areas of practice. So you're going to need to know this for the exam, so please make sure that you're paying attention and maybe even taking notes on this. So when we talk about medical-based settings, this is a hospital, a clinic, industrial, home health care, and nursing home facilities. So this is, when we think of this is medical-based because there's medical care there. It could be a physician, it could be a psychiatrist, it could be a nurse practitioner, it could be nursing. There's some kind of medical component based out of these settings, which is why we call it a medical-based area of practice. Now, you might say to me, why on earth is an industry considered a medical-based practice? If you're working in an industry, and I'll say like Anheuser-Busch, okay, so Anheuser-Busch is very well known. They have their own medical-based facilities there. So therefore, if their employees get hurt on the job or they come in and they're not feeling well, they can get medical attention in those settings. They can also get rehab in those settings, like an OT or a PT evaluation and treatment. So that's why it's based under that medical setting. When we talk about sociological based areas of practice, these are areas of schools. Okay, this is a day treatment program. These are workshop settings for individuals that have developmental or mental disabilities. And they're also community organizations like camps. I'm sure you've heard of Camp Good Days, or I am friends with an individual that runs a camps for burn victims. So that's what we're talking about for sociological based settings. OTP can be provided in any of these areas. Psychological, this is looking more at the psyche. This is looking more in the mental health. So we're looking at institutions or psychiatric centers, community mental health centers, teen centers, supportive or supervised living facilities, after-school programs. These are looking at homeless shelters. Okay, this is that psychological area of practice. OTs are working in these areas that are providing the services for individuals to lead the best life that they can, given their deficits, and depending on where they are in their recovery process. The next one is non-traditional. This looks at emerging areas of practice. So these are looking at productive aging, which we talked about before, aging in place, work industries, looking at ergonomics, so how to keep employees safe at their work environment. Okay, that's something that an OT can do through a non-traditional area of practice. And then looking at general wellness-based programs. How to keep people aging in place, how to keep people safe in their homes, how to provide people with adaptive equipment more on a general basis. So that's what we're talking about when we mention non-traditional settings. So what do OTs do, or how do the OTs spend their time in each setting? So when you look at each of these areas, it just talks about the longest bar in all of these is looking at the direct client intervention, which is good, right? You guys are not getting into the OT field because you want to sit behind a desk all day. At least I hope not. You want to work with clients. So in any of these areas, you will see that the longest bar graph here is indicative of showing how much time an individual or an OT spends with direct client intervention. But then you'll also see that there's indirective or administrative issues or areas that need to be addressed, as well as consultation with clients, research, and then other functions. So when we talk about the indirect and administration, a lot of this is covered under documentation. There's a lot of documentation that goes into being an OT as well. And as you see, the documentation will vary depending on the setting that you're in. Okay, so what kind of OT will you be? So I'm going to have you click this link. We'll stop here for a minute. You're going to click this link and you're going to take this quick quiz. It's kind of a fun quiz. It's not very highly research based, but it's just kind of fun. And then I want you to share with me what kind of OT you will be based on your responses to those questions. This is, so now we're going to talk a little bit about pediatric OT. So this is me with my little friend Seamus, who I just love. This was many years ago. Seamus is now going into middle school, but he has Down syndrome and he also has autism. He's a fantastic kiddo and I just love him to death. And I just wanted to share that with you. So when we work with pediatrics or we work with child-based programming, we're not just looking at the child. We're looking at the whole family. It's a whole lifestyle. So we have the individual that, so say we're working with Seamus, okay, who is, I've started working with him when he was 8 months old. You can imagine what I do with him is going to carry over to the whole family. The whole family is involved in this process of helping a child get better. Okay. We also look at their lifestyle of the child and the family, whether it's their ethnicity, their religious in terms of cultural or spiritual or religious beliefs that they have that may play a part in our therapy intervention. We also look at the socioeconomic status of the individual and then what is the parenting style. You would think that the parenting style would be the most important, and oftentimes it is, because everybody parents differently. And we have to appreciate that. We have to respect that. And we have to not ask them to do things that are out of their control or their belief systems, because ultimately they're the controller of that child. So we have to understand what those parenting styles are and how it meets the needs of the child that we're working with. So the next area is neonatal intensive care. I'm going to have you look at this, and there is a video clip here. It just shares a story about actually she's a neonatal intensive care nurse, and but it shares her story with her child, which I think is, if you're not familiar with this environment, you might find it to be pretty interesting. My question here also is, are you or do you know of somebody that was born prematurely? And if so, did you or did an individual you know spend time in a neonatal intensive care unit? So neonatal intensive care units care for ill and or premature infants and their families. So they're very, it's a highly specialized field with neonatologists and physicians and nurse practitioners, therapists that have extensive education and understanding of what happens in this neonatal period. Children that are in this environment are easily affected by their environment. So the priority is ensuring that they are providing sensory and experiences that will help the child to develop in the most optimal way, in trying to alleviate issues that in terms of sensations that are not as desirable and try to reduce those. When children are in neonatal intensive care units, there's a lot of poking and prodding and in 24-hour care. And so we want to make sure that the child is still able to develop as normal as possible, which comes to our goal. So the goal is optimal infant development. So we want to make sure that they're developing the appropriate occupations, that their sensory motor processes are developing in an appropriate manner so that there isn't any long-term effect. And that is also in terms of neurobehavioral organization of their body, so that there isn't any long-term effects as a child leaves the neonatal intensive care unit and goes into the next areas of or settings of practice or practice settings. Often the OT, when they work in this setting, they use a sensory integration approach, but we also do positioning and we do splinting and we do a lot of parent education. This is just continuation of the slide. So we adapt the stimuli that the child is exposed to, and we want to make sure that we're providing the child, if the child is stressed out, when a medical procedure is being done, how can we alleviate that? How can we provide them with a more optimal sensory stimuli so that they can but they can successfully get through that medical procedure. We also work with children on feeding and eating issues. I mentioned before about adaptive devices, splinting, or positioning as appropriate in parent education. So now I want to talk about each of these setting areas as we look at the OT process. So remember, we talked about this in the very first presentation of this module, the OT process. So we look at the evaluation. How are we observing the child? What data are we collecting? And how are we administering those assessments? We are then going to create an intervention plan that is individualized for that child. And we also coordinate the team to make sure that even though the OT isn't in that setting all the time or won't be working with that child all the time, the nursing and the physicians and other therapists are carrying over that intervention. We do consultation with parents, so that parents feel that they can do something with their child when they're in this sterile and very medical environment. And the ultimate goal here is that we want to plan for a safe discharge home. Okay. This is just a little picture of what can be seen in a NICU environment. So as you see, there's like a little isolette, and this is where the baby is held. And the environment that they're in, which is in the plastic like shell setting, will provide a uniform temperature for the child's body. And it has little armholes for the parents to reach into so that they can touch their child. At the other end, it has an opening for the if the child needs a ventilator or needs IVs or needs any other tubes that are going in, to allow them to go into those settings without disturbing the warmth and the sterile environment there. Just wanted to give you a little image of what this looks like. Okay, so now we're going to talk about early intervention. So this is a family-centered community service for children that are ages birth to 3 years of age. That's how we identify early intervention. It's a whole setup, and the systems are very regulated. So this is what we do is we work with children who are not meeting their physical or mental developmental milestones. There are certain medical diagnoses that are deemed high risk, and therefore those children automatically qualify for early intervention services. So early intervention services is a system that was developed and follows the guidelines of Individuals with Disabilities Act. This requires that children are seen in their natural setting and that all interventions occur along their daily or natural routines and their natural activities. Okay. The OT process for this is set up by a service coordinator, and it's set up, and it's outlined or documented on what's called an Individualized Family Service Plan, or an IFSP. So we will complete an OT evaluation, we will complete the intervention, and we'll set up goals, which therefore go on that IFSP, and then we start to set up how we're going to address those how we were going to address those goals, and then set up a discharge or a transition plan right at the beginning. The service coordination is provided by a different individual who oversees all of the therapists as well as the parents and keeps that open line of communication going between the two of them. So EI and OT, we look at family education. We're promoting the development of that child by providing them with the appropriate occupations for their age, adapting the task or adapting the environment in order for that child to be successful. We also spend a lot of time on fostering a bond between the child and the family and the parent, and empowering families to be advocates. So there's a great story. I'll try to post it if I remember it, and it's Welcome to Denmark. And basically it talks about, it's a poem based on a story from a parent that had a child with special needs. And it kind of talks about her life and how it changes. That you have all these expectations of having this child, and your child is going to, be beautiful and it's going to grow up without any problems or challenges developmentally. They're going to go to the prom, they're going to get married, they're going to do all these wonderful things. And now all of a sudden, you have a child that has a physical or developmental delay, and how that shifts and changes. And it's up to us as OTs to help the parents understand the disability of the child and foster and build upon that bond so that relationship can continue to blossom and grow. So we address the developmental milestones. We address their ADLs, such as play, sleep, participation, social participation, eating, bathing themselves, whatever those developmental milestones are. Here's an EI video of Catalina. It's an EI session, so I will let you look at this again on your own. I think it's a really great video. It's not very long, but it shares an example of what this looks like. Then we get into school-based program. This is a time we're going to think about 3-year-olds to up to 21. Generally speaking, school goes from kindergarten through 12th grade. But if you have a child that has developmental disabilities, it may start as early as 3 years of age, and they can actually go under the regulations of IDEA up to the ages of 21. So this looks at, what is their classroom like, their playground, the pool, the community. We have public schools, we have charter schools, we have alternative school placements, we have homeschooling. Children now are going to have what's called an IEP. This is a legal document that allows for related services such as OT and PT to be integrated. And if a child doesn't qualify for an IEP, they can use a 504 accommodations plan. On the right side here, you'll see these are things that we look at. We want to see how the child participates within the school environment, in their classroom, in the playground. What are their self-help skills, their adaptive skills, much as those dressing and bathing and toileting? Are they able to do it for themselves? Where are they in the developmental progression? How are they able to socially participate with others? If they have a physical or a verbal impairment, how are they participating with peers? And how can we promote and optimize that to be the most successful? What is their mobility? Their social emotional learning. Are they able to transition between tasks in the classroom? Are they able to engage in a productive way with children and peers their age? Are they able to follow directions? That's what we talk about with that social emotional learning. We look at them within their environment. Are they able to safely navigate within their environment? And then we're also starting to prepare for transitions. Transitions from preschool to school age, transitions from school age or elementary school to middle or high school, transition from high school into community for employment or into college. So we're always looking at those transitional components. Here's just 3 little videos, which I think are just great. The top one on the left, this is peers that are in circle time, which is very common in elementary school. But here the child is sitting in an adaptive chair because he looks to me as if he has some low muscle tone. So it might be difficult for him to sit with his peers, but providing him with an adaptive sitting device, he's able to do so. The one below that is a little boy in physical education class playing basketball. Physical educators or phys ed teachers certainly know the skills of how to teach somebody to play a sport, but they may not know how to teach a child to play a sport that is in a wheelchair. That's where we come in, and that's where we can help out. The one image on the right is an individual in a life skills class. So this individual looks as if he has a developmental disability and possibly even Down syndrome, just by looking at some of his facial features here. And so teaching them the steps of how to cook for themselves and how to be able to be self-sustaining. This is all part of the academic programming. Then when we get into hospital settings, we're talking about inpatient hospital settings. These are working with individuals with critical medical conditions, and the ultimate need is for medical intervention. Some of the diagnoses we might see is somebody that has an amputation, somebody with arthritis or cancer, hand injuries, neurological disorders such as a cerebral palsy, brain tumors, TBI, could be a stroke, things along those lines, trauma, and other medical conditions. Our goals for OT's point of view is that we want to stabilize and restore function. Again, the medical physicians and the medical personnel are going to be addressing their medical needs. We need to make sure that we're keeping up with their strength, keeping up with the individual's psychosocial aspect in order for them to restore function. So we're going to look at how they're doing with their activities of daily living, what are their physical, perceptual, cognitive deficits, their sensory integration skills. Again, looking at family education. When people or individuals go into a hospital setting, they may not have ever been there before. And so the families may not understand what's going on. Physicians talk very quickly. Medical personnel talk very quickly and often use medical jargon that individuals or family members don't totally understand. We can help take care of that gap a little bit so that they are better understanding what's going on with their patient or their loved one's life. As we're getting ready for discharge, we're looking at what their home environment is like. Do they need adaptive equipment? Do they need any kind of orthotics or splinting or wheelchairs or durable medical equipment such as canes or walkers prior to discharge? The next one, and this is the last one we're going to talk about, is inpatient rehab or outpatient OT. So this is addressing needs within the skilled nursing facility or within the community. So these referrals are made from a physician or can be also done through private pay. But we still need that physician's order in order for us to treat. We need a physician's script or prescription in any of these settings that we've talked about thus far. The OT process, again, looks at the evaluation, consultation with the family, and intervention. On the right here, we have a list of diagnoses that we work with: developmental related disorders, such as autism or ADHD, sensory processing, learning disabilities, etc. Upper extremity injuries or hand rehabilitation. Ortho concerns, somebody who's had a hip replacement, knee replacement, maybe a back injury. Mental health. One such example is anxiety, but there's many more of that. Trauma recovery. This goes into if somebody's been in a motor vehicle accident, has fallen, has been burned, some kind of trauma has happened. Traumatic brain injury, delays in fine or visual motor skills, delays in coordination, feeding difficulties. And then other neurological or ortho conditions such as cerebral palsy, brain tumors, cancer, etc. So we can see a variety of disabilities in an outpatient setting. Okay, that's it for this presentation. I hope that you have at least a better understanding of what other treatment settings are, and I'll be talking to you soon. Thanks, guys.